just to quickly introduce, our speaker. Her name is Lauren Salame. I hope I pronounced that correctly. And she is the Assistant Fellowship Director at Harvard Emergency Ultrasound Fellowship and practices at the Brigham and Women's Hospital. I'll let her do the more detailed introduction since this is going to be her session to lead. Thank you, Lauren, for taking the time off to conduct this session, and we're very excited. You can go ahead.
All right. Thanks so much, Faith. You actually pronounced my name quite well. My name's Lauren Salame. I'm an ultrasound faculty member at Brigham and Women's Hospital in Boston, Massachusetts. I believe some of my other colleagues have lectured with you guys as well. And today I was asked to talk about pelvic ultrasound. I'm focusing on first trimester pelvic ultrasound. I'm planning to go through transabdominal, transvaginal ultrasound. In full transparency, I really don't know what you all practice on your own already, if you're already doing pelvic ultrasound, if you're doing both of these modalities or what. So feel free to share, feel free to chime in during the presentation. I hope nothing's too repetitive for you, and I welcome any interaction or less interaction if that feels more comfortable. The objectives of the talk will be to review the technique for both of these modalities of pelvic ultrasound, transabdominal and transvaginal. We'll go through the different probes that we used. For transabdominal, this curvilinear, and transvaginal, the endocapillary probe, the indications for this examination, and really what are we looking for when we do this, which is we're looking to confirm a pregnancy, a definitive intrauterine pregnancy. We're looking for signs of ectopic, and we're looking for features concerning for ruptured ectopic. All right. And as far as our indications, who we would do this exam on, it would be really any woman of childbearing age, anyone that could possibly be pregnant, and that might be explaining what symptoms they have going on, which could vary from abdominal pain to nausea to vaginal bleeding, unstable vitals, syncope. And when do we perform each of these transabdominal versus transvaginal? I think you do transabdominal first, and if that doesn't help you enough, then you switch to transvaginal. So I think one of the first questions you would ask is, as an emergency physician, is this an exam I can do, and should I be doing that? And there's actually really great literature to support you all performing this study. This is a systematic review. It's showing really high specificity for intrauterine pregnancy, a 98% specificity, and then a 90% sensitivity. And there's a reduced incidence of missed ectopics and reduced time to operate, the reduced waiting time to go into the operating room by employing pelvic ultrasound in the emergency department. Overall, there's a decreased ED length of stay for all patients too. And then in this meta-analysis, it again shows this one specifically is looking at for ectopics rather than before we're looking at intrauterine pregnancy. This one's showing a high sensitivity and specificity for ruling in ectopic pregnancies. So as the bottom line, focus rarely misses intrauterine pregnancy, and you should use this opportunity to rule in the possibility of ectopic pregnancy. All right, so here's kind of starting with an image which might be hard to interpret, or you might notice some abnormalities in it. Like, first thing to see, this is a transvaginal ultrasound, because you can see like there's this 180-degree footprint of the probe, which is characteristic of an endocapillary probe. And to just kind of outline for you what we're actually seeing, this is the uterus. The fundus of the uterus is here. And this would be the lower uterine segment leading to the vaginal stripe would be down here. Inside the uterus, which is here, we actually see a gestational sac, and you see stuff within it. So there is an intrauterine pregnancy. But then we also see an arrow pointing over here. It's nicely labeled as ectopic gestation. So there's both an intrauterine pregnancy here and an ectopic pregnancy. So this can sometimes be people's concern. We can rule in an intrauterine pregnancy, but does that mean that we're ruling out an ectopic? So this particular occurrence is called a heterotopic pregnancy, which means, there's two pregnancies, one in the uterus and one outside the uterus. It used to be very, very rare, about 1 in 30,000. This was before reproductive technologies. So essentially, if you saw an intruding pregnancy, you were nearly ruling out heterotopic pregnancy. Now, the rates of heterotopic pregnancy have increased. In the general population, it's 1 in 4,000. But for patients undergoing IVF or some other reproductive technologies, the rates are 1 in 100 for heterotopic pregnancy. What this means for our general practice is I just always confirm with the patient if this is a natural pregnancy or not. And if it's not a natural pregnancy, I wouldn't stop at my own pelvic ultrasound for determining if there's only an intrauterine pregnancy and nothing else. So if they're an IVF patient, I would make sure to get a transvaginal ultrasound, and I would try to talk with our obstetrician, which I don't know if you see IVF patients or not, but for us, if we see an IVF patient, they 100% have an obstetrician because someone gave them those medications, if that makes sense. All right. So now that we know ultrasound is a great tool to use for this, for ruling in intrauterine pregnancies and ruling out ectopics and heterotopic pregnancies, we only really need to worry about if the patient is an IVF patient. We'll go over our technique. So first, we're starting with the transabdominal view. To do this, we prefer the bladder to be full. This creates a nice acoustic window for the sound waves to travel through that fluid and then go to the uterus to see our point of interest. The large bladder also displaces bowel gas, which can get in the way of imaging. This is a little probe, and our window is the bladder. All right, and then no matter what probe you're using, you do always want to try to choose the OB settings. This will be safest for the fetus, as well as it opens up any measurements that you want, and the ultrasound will open up any measurements that you want to use, such as the fetal heart rate or crown rump length. Those options are only available if you choose OB settings. And we're actually going to talk about nearly all of these probes. This is the curvilinear probe. It's the ideal probe for the transabdominal ultrasound. If you don't have a curvilinear probe, you can use the phased array probe. And if you want some better visualization just of the gestational sac, sometimes it's helpful to actually use a linear probe. I would never start with a linear probe. That's an adjunct. And then if you still can't see anything, then you switch to transvaginal ultrasound. Okay, so our minimum criteria for doing the scanning protocol is to have at least 2 views of the point of interest. So 2 scans through the uterus, because that is our point of interest. And I would perform these scans in both the sagittal plane and the transverse plane. You also want to take any relevant stills, and if there's any other important structures you note, you would want videos of that as well. This is the trajectory of first trimester ultrasound. So early on in pregnancy on the left here, all we have is just some endometrial thickening. You can see this white portion in the middle of the uterus. That's the endometrium, and it's thicker than usual. After that, we see something called a double decidual sign. Might be a little bit hard to see in this small image, but around this, so this is the uterus, and then there's an anechoic sac within it. And around that sac, there's actually 2 more hyperechoic lines, one right outside of the anechoic sac and one a little bit further. It's called the double decidual sign. Specifically, radiology will use this. Radiology and obstetrics, depending on their comfort level, will use this to say there is an intrauterine pregnancy. Notably, in the emergency department, we don't use, this isn't enough for us to say there's an intrauterine pregnancy. What we want to see is the actual yolk sac, which is right here. It looks like a white Cheerio within the gestational sac. Here you can actually see the double decidual sign better. There's white, white, and then inside there's this little Cheerio. And notably, they used a linear probe to see that. And then after 6 weeks, you start to see a fetal pulse and a fetal heart rate. So this yolk sac and the fetal pulse, heart rate, those are the things we're looking for with transabdominal ultrasound and with pelvic ultrasound in general. All right, so this is where you place the probe. It's kind of angled a little bit down so that you're looking toward the pelvis, and the probe marker is up when you're looking in the sagittal view.
Lauren, could I ask something? In the previous diagram,
Sure.
there were 2, in the last image, there are 2 anechoic areas. So what's the one at the lower part?
Yeah, that's a really
That
good.
one.
Yeah, very good question. I think we might actually see this image again. But so here, this is, well, first, this is a transverse view of the uterus. Here's the uterus here. This is the gestational sac. And you can actually see the fetal pole here. And down here, you always need to clinically correlate what something might be. But in a patient that isn't really having pain, you might be a little bit less concerned and might recognize this correctly as a luteal cyst. So luteal cysts can happen during the first trimester. They do go away, I think around like week 10, I want to say, you stop seeing luteal cysts. But that's what this is. If a patient, of course, has like unilateral severe pain, then you always want to be concerned that that could be a cyst that could be torsed. But this is a luteal cyst helping to support the pregnancy.
Thank you.
Yeah. All right, so this is a sagittal view of this woman's uterus. So we have bladder down here, and this is vaginal stripe. The cervix would be here and lower uterine segment, and this is the uterus. Posterior to the uterus is where we would look for free fluid. This area is called the pouch of Douglas, or the, I guess just like the rectouterine area. I think I'm blanking on the other term that you use for it, but this is where you might see pelvic free fluid. And if there is concern for a ruptured ectopic, which would be something that can cause pelvic free fluid, you should always look in the right upper quadrant as well. Oh, here's that image again, actually just a little bit larger. I'm sorry, but it's a 31-year-old. She's a G1P0, 9 weeks pregnant, and she does come in with some abdominal pain. This is the ultrasound you perform. You can see this nice little heartbeat, and you do see this cyst down here. And this case is to show us how we perform fetal heart rate measurements. You always want to use M mode. So this is the M mode line tracer right here. You want to put it over the heart rate, and then you'll be able to find the repetitive motion down here and mark it. You'll notice actually that on every machine, this is something that you need to be in the OB settings to do, but in every machine, when you open up your fetal heart rate tracing, it will tell you how many beats to look for. I don't know if this is something that's confused people before. It used to confuse me a lot. It says 1 right here. So you just need to identify 1 beat. 1 beat, next beat. Some machines ask for 2 beats, is why I mentioned this. So then instead of going 1, 2, you go 1 and then mark over here. And then it'll kind of average that time and give you the heart rate in that manner. When doing this, you always want to be sure not to use any Doppler, just so that you're minimizing any potential exposure to the fetus. These are the normal heart rates that occur during pregnancy as well down here. Okay, so for this patient, she theoretically could have waited a little while if we decided to order a radiology ultrasound or call obstetrics, whatever your protocol is for ultrasounds. But if we do ultrasounds through the emergency department first, it has been shown that there's a significant reduction in the time the patient waits in the emergency department, about a 1 to 2 hour reduction in ED length of stay. And if we combine this with the fact that we can safely perform it, of course, it seems like the right thing to do, I think. All right, so another case. This one was 25. She presents after syncope, which is concerning, but her vital signs are normal. And you do a pelvic ultrasound. You have no idea if she's pregnant, but here we see a bladder, we see a uterus. I don't see anything specific within that uterus, but I don't know if any of you noticed this, but we actually see free fluid behind the uterus. It's a little tricky because it looks sort of gray. It's not as black as this bladder. Sometimes the fluid's more obvious than others, but there is certainly free fluid in this scan. And then that operator moved on to look at the right upper quadrant, and you can see free fluid in Morrison's pouch right here. This is the left side. So kidney, spleen, there's free fluid down here, as well as up here and there. And this structure can trip people up. Sometimes it's actually the stomach. but that's just showing there's free fluid in the pelvis, the right upper quadrant, and the left upper quadrant. So all of that is concerning for ruptured ectopic pregnancy if the patient's HCG is positive. Here's another example of some free fluid. So this is actually a pelvic view, and you see just these little bits of fluid all over the pelvis. It's just sometimes not as obvious actually in the transverse view of the pelvis as it might be in the sagittal view of the pelvis and as it is in the right upper quadrant. This looks like it's switching to a sagittal view of the pelvis right here, and we can see this obvious fluid around the bowel loops. And then looking in the right and left upper quadrants, it's subtle, but you can see a little bit of free fluid right up here. And it looks like right above the spleen here. So what's the importance of seeing fluid in the different areas? There's actually been a study that looked at free fluid specifically in Morrison's pouch on bedside ultrasound and if it predicts the need for operative intervention in suspected ectopic pregnancies. And indeed it did. So in this study, 23 of the patients had free fluid just in the pelvis, and 10 patients had free fluid also in Morrison's pouch. And of those 10 patients with free fluid in Morrison's pouch or in the right upper quadrant, 9 of them needed to go to the OR for operative intervention of a ruptured ectopic pregnancy. The 10th patient had a ruptured luteal cyst and had a definitive IUP also on the ultrasound. So 90% of the patients that had fluid in the right upper quadrant went to the OR, whereas only 9 of 23 of the patients that had free fluid in the pelvis required going to the OR. So not having fluid in the right upper quadrant doesn't mean you don't need to go to the OR, but it's highly predictive of needing to go to the OR. Another thing to always remember, it said right here, ruptured ectopics decompensate quickly. So women will hide kind of their vital sign abnormalities. They might even hide in their lab work the fact that they're bleeding into their pelvis. They might just have normal vital signs, might even have normal labs, but soon they will decompensate, kind of like the patient that came in with syncope and then she comes but has normal labs. So always just keep this high on your differential. All right, so this patient just came in saying, I had a pregnancy test at home that was positive, and she has no complaints, no belly pain. Someone ends up ultrasounding her. This is what they see. So looking at this ultrasound for you, notable things to see are first you look in the uterus. I don't see any definitive IUP. This is outside of the true realm of emergency ultrasound, but there is a thickened endometrial stripe. It's non-specific. It can happen in early pregnancy, but it can also happen during menstruation. So it doesn't really mean so much. Looking behind the uterus, I don't see any free fluid. So that's a really important thing though, because I'm not concerned for ruptured ectopic. But in reality, I wasn't concerned for ruptured ectopic from the get-go because this patient had no symptoms. So the question is, do we need to do anything? And did we need to ultrasound her? For asymptomatic pregnant women, you really don't need to do any routine ultrasounds. You should be sticking with your clinical indications. Okay, another case. So 35-year-old woman, G1P0, she's 6 weeks pregnant by LMP, and she has abdominal pain. So you perform an ultrasound. Let's see. We see the uterus here. I can see some sort of sac in here. I honestly can't tell for sure if I see anything inside it. I do see posterior to the uterus that there's this cyst. It might be a luteal cyst. It might be something more concerning though. And here's an example of someone then switching to the linear probe because they couldn't see that gestational area well enough. And you can see this little Cheerio sign right there. That's the yolk sac. So that's the first sign we look for to discern if there is an intrauterine pregnancy. And this woman's pain all went away when she was told that her pregnancy was in the right spot. I feel like that happens often for patients or just like if they have some water or some Tylenol and suddenly their pain is better, and I'm less concerned about any abdominal pain being anything pathologic for them. This is also outlining what that double decidual sign that I mentioned is. These are the two hyperechoic stripes. You'll see this in your normal pregnancies. But again, I don't use this to rule in intrauterine pregnancy unless I also see a yolk sac. This is another example of the double decidual sign. Hyperechoic here and hyperechoic out here. And here's a big reason why we don't use the double decidual sign or just having a gestational sac in general to rule in an intrauterine pregnancy. Ectopic pregnancies can actually create some changes in the endometrium that will create structures called pseudo-gestational sacs, which is what this is. This is just a small anechoic sac, and there's some thickened endometrium around it. But this is not an intrauterine pregnancy and could be mistaken for one if we just use gestational sac or double decidual sign as our ruling criteria for intrauterine pregnancy. All right, so this is a patient who comes in with belly pain. She's 5 weeks pregnant by her home urine pregnancy test that was positive. And you perform an ultrasound. Here's one of the stills you took. This one's a little bit advanced and tricky, but this is the endometrium. This is a gestational sac. To be honest, I don't see anything in it in this particular still. There might be clips that actually show that there's something inside it. But what the operator did was measure from the end of the gestational sac to the end of the uterus. And this is called the endomyometrial mantle. It should be at least 8 millimeters to support a pregnancy. And if it's less than 8 millimeters, that's suggestive that the pregnancy implanted actually in the corneal areas of the uterus/fallopian tubes, and that the uterus won't be able to support the pregnancy. So in this case, it's 0.57 centimeters, which is notably too thin to support a pregnancy. So the steps I would do if this were the case, I would contact OBGYN. They likely will ask for a more comprehensive ultrasound, which I think is fine. And they can use all of that information to make their decision on the patient's management. And this is again just showing where we would do that measurement. So it's from the end of the gestational sac to the end of the uterus at the thinnest portion. Okay, so a 41-year-old female, she's G3P2. She's 8 weeks pregnant, and she has some vaginal bleeding. Here are our ultrasounds. So bladder's here, uterus is here. We can see a gestational sac with something inside it here. So that is suggestive that there was an intrauterine pregnancy, which is great. But you can actually see some anechoic structures around it. They're seen over here as well. So these would be subchorionic hemorrhages. The important thing to counsel a patient on regarding this is that they have a higher risk of having a miscarriage if they do have a subchorionic hemorrhage. It doesn't mean they will have a miscarriage, but there is a higher risk. So I do think it's kind of important to tell the patient that. It's sort of similar to when you're having a discussion about a threatened abortion with a patient, the patient that just comes in with vaginal bleeding and you find out they do have an intrauterine pregnancy, but actually that vaginal bleeding increases their risk of going on to have a miscarriage. Not that they did anything wrong, it's just the risks that are higher than they were if you didn't have vaginal bleeding. They should have OB follow-up as well. And other things to consider, of course, any patient with vaginal bleeding is their RH status to see if they need RhoGAM. I know it is actually, the practice is different, I think in every country, or if you give RhoGAM in the first trimester. In the emergency department in the US, we do still do this. I know maybe some OB-GYNs don't practice it necessarily in the outpatient setting, but from a more conservative approach in the emergency department, we do still give RhoGAM for first trimester bleeding. And always check for asymptomatic bacteriuria in your patients. because that can also increase chances for complications in the pregnancy. Okay, kind of reviewing how we do dating for the fetus. So first trimester ultrasound with crown rump length is the most accurate form of doing this. So it is ideal for the patient to have their dating ultrasound earlier. It's done just by going from the crown or kind of the head to the rump of the size of the fetal pole. You don't want to include the yolk sac in this measurement. And then later in pregnancy, you can use the biparietal diameter, which is done here. So they find the head and bring it into transverse view. And you go from leading edge, kind of the top of the skull, to the leading edge, like the first part of this hyperechoic skull in the back. Or you can do a femur length, which is shown here. These are less accurate, and we really do them a lot less in the emergency department. Crown rump length is typically what we do, and that's just, but you can only do that in first trimester. All right, so we actually made it to transvaginal ultrasound. So if you've performed a transabdominal ultrasound and it's not quite conclusive, then you should consider doing a transvaginal ultrasound if you do have access to that probe. The transvaginal probe is a higher resolution probe. It goes closer to the structure of interest, so it will give you a crisper image. You want to perform this examination with an empty bladder, a chaperone, and a probe cover, of course. You need to elevate the pelvis in order to perform this exam. So you can use things like a bedpan or a stack of sheets, or if you have a gynecologic stretcher, that will be helpful as well. And you can ask the patient if she prefers to place the probe herself or prefers to have you place the probe. Reasons not to do this would be any concern for rupture of membranes or placenta previa. So I personally would only do this in first trimester. I wouldn't do it in second or third trimester. Here's how you set up the probe. You would put gel on the probe first, and then put a probe cover, and then put more gel. This is the probe indicator, and we'll go over what direction that probe indicator should be facing. So in the sagittal view of the uterus, the probe indicator is facing up or 12 o'clock to the ceiling. And this is the view it will give us. You see, this is a cut of the bladder, the uterus. This is the pouch of Douglas here, and the rectum. And here's that view. Up here would be where the bladder is. This is the uterus. And rectum and pouch of Douglas is back here. There's no free fluid. And there is a gestational sac. Do we see? Oh, and we see a yolk sac inside it. So that's great. All right. And then switching to the transverse view. To do the transverse view, you'll put on the left is the sagittal view indicator up. On the right is this transverse view indicator to your left or patient right or 9 o'clock. In the sagittal view, you'll sweep left to right to get a full view, sagittal view of the uterus. And the transverse view, you sweep up and down. And here are those sweeps sagittal. We're going left to right. And transverse, we're going up and down. This will also give you better visualization of the adnexal structures. So this is the right adnexa and sagittal and transverse views. So to look at the right adnexa, you're going to move your hand kind of toward the patient's left leg so that the footprint of the probe is looking at the right adnexa. And it's the same thing on the left, except you'll bring the probe toward the patient's right leg so that the probe footprint is looking toward the left adnexa. So we went over the fact that this is a better resolution image because it's a higher frequency probe, it's closer to the point of interest, and it is also more sensitive for definitive intrauterine pregnancies and ectopics. It identifies structures about 1 week earlier than the transabdominal views do. Here we have an image, a transvaginal ultrasound image, sagittal view of a uterus with a gestational sac with a yolk sac within it. And then down here, looks like we have an adnexal view of a ectopic pregnancy. Yep.
Lauren, could you just point to some of the adnexal structures just so that we get a better idea in the transverse view?
The transverse view, like over here.
Yes.
So, okay, so we can see here, the uterus is here. We have an endometrial stripe here. And then right here, so we know that the uterus adnexal is nearby, but not there. And we actually see the ovary coming in right here. There's these anechoic follicles, 1, 2, 3, 4, and it is very quick, but that's the ovary right there. And you would look for any cysts around there, anything that might look like a cyst that's actually an ectopic. Over here, right here, we see the ovary right here. Sorry, it is very quick, but it's kind of like a gray oval, and then within it, there's a handful of black circular follicles.
Okay, thank you.
You're welcome. All right, we kind of saw this image before. Again, we don't use these signs for bedside ultrasound. And the transvaginal hotspot is really when it's just a yolk sac. I think once there's a fetal pole, typically you should be able to see that by a transabdominal ultrasound. But if the patient only has a yolk sac, that can be difficult to see on transabdominal, especially if the patient has extra adipose tissue or if their bladder is just empty and you're having bad transabdominal views. Okay. So another case, 35 G1P0, 6 weeks by LMP. She has vaginal bleeding. These are transabdominal views. So we see a uterus, we see a gestational sac. We see that gluteal cyst below again too. And then this is just an example of that's the perfect patient to do a transvaginal ultrasound on. And we see that yolk sac again. And this would be an intrauterine pregnancy, but also a threatened abortion because she had the bleeding. So of course, check her RH status, make sure she doesn't have a UTI that you need to treat, all of those things that we like to do for our patients. Ooh, this is gonna be fast. So this is a 32-year-old woman, G2P0. She's 6 weeks pregnant by LMP, and she has belly pain. The transvaginal ultrasound yesterday was suspicious for an ectopic. So let's see what we can find. This is a transvaginal ultrasound. Over here, this is all uterus. We don't see anything in the uterus, like no anechoic sacs. I see it, well, it looks like a thickened endometrium though. It's all like, light gray, white there. And then a transverse view. Let's see, there's something over here. So that would be her right adnexa. It looks like there could be some structure there. If you see this, it looks like a thick walled cyst. But this pregnancy was really desired. So since they weren't sure it was definitely an ectopic, they did opt to monitor her. And you can only really do this for a patient that is clinically stable. And I would always involve OB in that decision. So after this, ultrasound comes back indeterminate, but it has that cyst there or like adnexal structure concerning for ectopic, I would consult OB at that point, and OB saw her and they decided to monitor. Okay, so then this is their ultrasound that is done today, so it's the day after that first one. And here again is that adnexal structure. It looks even thicker in this ultrasound. So this hyperechoic thickness here, and then there's just a central area right there that's anechoic. And I actually want to say I see a little yolk sac within it. Do you see that? I wonder if I can stop it actually. Right there. Ooh. Right there. There is a little Cheerio sign within there. So that's an adnexal structure that actually has a pregnancy within it. And that image actually has a name. It's called the bagel sign because it looks like, it's thick here, looks very similar to a bagel. Oh, and just to go over what were her labs, she was Rh positive, so she did not need a RhoGAM. Her beta HCG was greater than 3,000, and it didn't really change, it looks like, from yesterday. So again, that's that ectopic. And of course, we had to call obstetrics. Here are some other tactics you can use to look for ectopic pregnancy. You can put color flow right on your suspected ectopic, and this is called the ring of fire sign. Ectopic pregnancies can have elevated vascularity around them. Radiology will use this to help determine if there might be an ectopic. But it is important to know that this can also be a normal finding that will be seen in maturing follicles or corpus luteal cysts. Therefore, the ring of fire sign should not be used independently to diagnose an ectopic, but I think it's nice to know about and to be able to understand what it means if you see it in a radiology read. So in that case, that patient did end up going to the operating room with OB to have that ectopic taken out. All right, we just have a few more cases. I hope I'm doing okay on time. This is case 10. It's a 26-year-old woman. She has an IUD, so really she shouldn't get pregnant, but she's had 2 weeks of abdominal cramping and she has normal vitals. This is her transabdominal ultrasound. So we see a bladder here, uterus here. You can actually see some shadowing from the IUD. That's this black stuff coming down. That's just a shadowing from the intrauterine device. And then posterior to the uterus, we see this structure that is like thickened walls, anechoic center, and there is a little yolk sac or fetal pole right there. So of course, when we see this, we're concerned for adnexal ectopic and we want to call obstetrics. At our institution, our obstetric colleagues asked for a transvaginal ultrasound, which we did try to say, we have transabdominal ultrasound that has this diagnosis on it, but they still wanted it for their planning purposes. So it means that we get to look at it. So let's see. This is a sagittal view of the of a transvaginal ultrasound. This really is just showing empty uterus, and you can see that IUD in the uterus. And then in our transverse view over here, we do again see the IUD over here, but we also see outside of the uterus this structure right here with a fetal pole actually inside. Right there, that's the fetal pole. And her HCG was 66,000. Wow. There's the heartbeat. And of course, this patient needed to have that ectopic taken out. And you can see the free fluid again as well. So there's concern that it is rupturing. Any patient with an empty uterus and pelvic free fluid, positive HCG, should make you highly concerned for a ruptured ectopic. Our next case is a 26-year-old woman, G1P0. She's 2 weeks pregnant by LMP and she has vaginal bleeding, abdominal pain, and she is tachycardic. So she had an empty uterus on her pelvic ultrasound. I don't know if I missed it in my clicks, but this looks like the right upper quadrant and the left upper quadrant where we see the free fluid. So having free fluid and empty uterus is concerning for a ruptured ectopic. Other important things to notice about this case, she's a little bit tachycardic. I mentioned women can hide their vital sign abnormalities. So that's probably just her beginning signs of severe shock, that she has a little bit of tachycardia. And a patient that is 2 weeks pregnant really shouldn't have any belly pain related to her pregnancy at all if it's a normal pregnancy. Only ectopics should be causing any belly pain at 2 weeks. Unless, of course, she had something else going on. These are the transvaginal views of that patient. You can see fluid everywhere. OB had asked for these transvaginal ultrasounds, I think, to try to see if they could see the ectopic, but often ectopic pregnancies are very often not found on the transvaginal ultrasound either, and they don't end up changing the management. So I'd always talk with OB about your patients before you put them through a transvaginal ultrasound if you feel like you already have the diagnosis. Okay, this is actually our last case. We went through a lot today. It's a 20-year-old woman. She has belly pain, a positive urine pregnancy test, and normal vitals. Trans-abdominal view. This is the bladder. It looks pretty empty, which might be why we don't have a great view of the uterus here. This is a sagittal view of the uterus. Some bowel gas, it looks like, is obscuring the uterus, but we don't see anything within it. And it would be hard to say if there's any fluid in the pouch of Douglas because it's obscured by bowel gas. But then transverse view, let's see, it actually looks like maybe there is something in the uterus there. It's hard to say though. And then our transvaginal ultrasound is done. This is a sagittal view. So we see the uterus in this long axis. We see the endometrium. And then we do see an anechoic sac in the endometrium, but I don't see anything definitively within that endometrial sac. Or just potential gestational sac. So for me, this is concerning for either this is an early intrauterine pregnancy, and we just don't have signs that say like this is definitely a pregnancy in the right spot yet, or this is a pseudo gestational sac and she actually has an ectopic pregnancy somewhere. So this is not a definitive intrauterine pregnancy. So our practice is if this patient is clinically stable, then she should be monitored every couple of days with repeat lab work, including beta HCG and ultrasounds, and follow up with OB/GYN. So, and that's really to see where is this progressing? Are we progressing to the point where we see an intrauterine pregnancy, or are we progressing to the point where we're like, oh, this is an ectopic pregnancy? So for these patients, you do always want to check the quantitative beta HCG and their RH status, of course. And we have certain guidelines that we use for determining when we have to call OB and when we have to just notify OB that we need them to follow up with this patient. So if they are clinically stable and they have no ectopic risk factors, no free fluid, and they meet our institutional guidelines for beta HCG, which for us is the beta HCG is less than 5,000, then they can just go on what's called a beta book and OB/GYN will follow up with them. But if they don't meet all of these criteria, then we call OB and OB has to actually physically come see that patient. So the important things to keep in mind are prior ectopic pregnancies, reproductive technology use, prior pelvic surgery, PID, and any patient with an IUD. OB should see those patients. These are the actual protocols that we use, which I basically just described though for all of you. So in thinking back, what are the clues for an ectopic pregnancy? Not seeing a definitive IUP always has to make you think, could there be an ectopic? Actually visualizing an ectopic pregnancy truly just rules in an ectopic. Having an adnexal mass, even if it doesn't definitively look like an ectopic yet, might the next day look like a definitive ectopic. And any free fluid, including pelvic free fluid or fluid in the right upper quadrant or left upper quadrant. Okay, so I don't know how much you all use the beta HCG guidelines. I think you probably do. So this is typically called the discriminatory zone, and sometimes people it's kind of like teetered for what our cutoff should be. So some people will say if the beta HCG is over 1,000 and there's no definitive intrauterine pregnancy on a transvaginal ultrasound, like that has to be an ectopic pregnancy. Um, that hasn't truly been shown in the literature. It is, and just we'll try to go through some of what there is to show. So this is a prospective consecutive enrollment study. So pretty nice study, but it is single center. All patients in their first trimester that have a pregnancy of unknown location have vaginal bleeding or abdominal pain. And the relative risk for ectopic pregnancy is actually far higher if the beta HCG is less than 1,000. So that's actually the opposite of what we typically think. Typically, we're like, oh, the beta HCG is this high. If there were a normal pregnancy, we would see it. But actually, lower HCGs are more concerning for ectopic pregnancies. And that's partly because ectopic pregnancies just produce HCG at different levels from normal pregnancies. Okay. And then we can wonder if maybe like 1,500 should be our cutoff. So this study is really, really interesting. Oh, sorry. What it's kind of showing is ectopic pregnancies are this black area here. And what are their HCGs? They tend to be lower. Abnormal intrauterine pregnancies. So that might mean, the pregnancy is not necessarily ectopic, but it's not sticking. The patient goes on to have a miscarriage. These are those gray areas. It's a little bit higher than the ectopic pregnancy one, but the normal intrauterine pregnancy is really the one that has the highest HCG. So again, it's kind of exactly the opposite of what the guidelines that we typically use. And it shows the mean HCGs for each of these patient groups. So ectopic pregnancy, about 1,800 is their mean HCG, and then it goes up for abnormal pregnancy and even higher for normal intrauterine pregnancy. And then this study looks at beta HCG levels of pregnant patients with indeterminate ultrasounds who went on to have an intrauterine pregnancy diagnosed subsequently on ultrasound. And there was no relationship with beta HCG and outcomes, but they do list these really interesting results showing how high these beta HCGs were for patients that initially had pregnancies of unknown location and then went on to have an intrauterine pregnancy. So these last these pregnancies did not end up surviving, but they actually were intrauterine. And then these other ones range from 2,000 to 4,000, and they were normal pregnancies that went on to deliver. So basically it's actually really complicated. It's not just a single cutoff, it's all like clinical correlation. And this is something to really involve your OBGYN colleagues in when you're determining what these beta HCG numbers mean for a patient that does not have a definitive intrauterine pregnancy. Kind of in summary of some of the other findings from these articles, beta HCG greater than 2,000. This is most likely a non-viable pregnancy. Non-viable is twice as likely as having an ectopic at this level. And then specifically at beta 2 to 3,000, ectopics occur 19 times more than intrauterine pregnancies. And the probability of a viable pregnancy is only 2%. And then greater than 3,000, ectopics are now 70% more likely than an intrauterine pregnancy, and the probability of pregnancy is only 0.5%. So just because the numbers aren't quite what we said they were initially, there actually is a lot of validity to these numbers and saying that it's very unlikely that this patient will have a normal intrauterine pregnancy. Overall, I think this is all just a gray area. It's good to be educated on it, but I wouldn't use any number to really say one thing or another and always involve OBGYN. So our final pearls, you always want scans in the transverse and sagittal planes for your patient. You start with a transabdominal ultrasound. If it's inconclusive, you can switch to transvaginal. And then even after that, if you have access to having radiology perform a scan, you can consider that if your transvaginal was inconclusive still. EMM is an endomyometrial mantle. If you see a thin wall around the gestational sac, I would measure what the endomyometrial mantle is. And in first trimester, you can measure the Cran-Rumpf length and the fetal heart rate. If there's concern for ruptured ectopic, always call OBGYN immediately. All right, and this is our last image, I promise. There is something different about this image from the ones that we saw before. And this is actually a uterus just going the opposite direction of what we usually see. The bladder is actually up here for the patient. We don't see it, but the uterus is going backwards. There's a little bit of fluid in the pouch of Douglas, and this is a retroverted uterus. It happens in 10 to 15% of patients, and retroverted uteruses do become anteverted during a normal pregnancy by the first trimester. All right, that's it. Thank you for your attention. I hope you learned something, and it was nice to get to join all of you.
Thank you so much, Lauren, for that wonderful discussion on pelvic ultrasound. So at this point, I would just like to open up the floor. In case anyone has questions, please feel free to unmute. We'll give it about 2 or 3 minutes to ask questions, and if not, we shall plan to close the session.
All right.
As we prepare to ask the questions, I'll just like to let everyone know that the recording for the session is going to be uploaded to the AFM website in a few days, and I've posted the link in the chat.
And this is also my email address if anyone wants to contact me at any time.
Great, thank you. Any questions from the group?
Yes,
Okay,
good evening.
Yes, doctor, go ahead.
Yes, thank you very much. This has been very informative discussion. I'm an obstetrician and gynecologist. My question is on estimation of fetal weight using abdominal circumference. I did some I have some idea on POCAS, but that has always been troubling me. I don't know whether this is the offside this discussion, but I would like just some small hint. Thank you.
Yeah, thank you for the question. I think it was about using the abdominal circumference to estimate the fetal weight. And I have to say that I am not educated on that topic, and I wouldn't be able to answer it. But I thank you for your willingness to ask a question and for listening to the presentation.
Thank you for that question, Taban. Anyone else with a question? Feel free to unmute. So Lauren, I just have one last question. I just wanted you to clarify what cutoff you said you use for your HCG levels in your practice.
Yeah,
you said it's a gray area, but
yeah, it's a very gray area. So it's always hard to explain, but the cutoff we use is 5,000. So if a patient does not have a definitive intrauterine pregnancy on a transvaginal ultrasound and their beta HCG is greater than 5,000, or if they have other risk factors for ectopic pregnancies, then OBGYN has to physically see our patient before they decide if the patient should be going home or if they think that this is an ectopic. If the patient has an HCG less than 5,000, then our practice is that we can discharge this patient with beta HCG and ultrasound follow-up.
All right. Thank you so much, Lauren.
Mm-hmm.
There doesn't seem to be any other questions. So I'll bring the session to a close. Once again, thank you all for joining us. We hope to see you again on the 29th of this very month. We have another session on procedural ultrasound, and the flyer will be going around with the link as well. We hope to see you there. Thank you all for joining, and have a good evening wherever you are.
Thank you for having me. Bye, everyone.
Thank you.